Good morning and good afternoon, everyone. My name is Donna Thorson. I am a senior project manager working with nursing homes in Nevada. I'd like to welcome you to our Hot Topics in Infection Prevention webinar series. These webinars are designed to provide you great ideas on infection prevention strategies in a 30-minute time frame to accommodate your busy schedules. We are excited about today's presenter. Dr. Eric Ramos is a board-certified family physician and former division chief medical officer for HCA's Far West Division in Las Vegas, Nevada. This position oversaw the 8 hospitals in the division. The responsibilities included oversight of 8 hospital medical officers and multiple teams throughout California and Nevada to improve quality of care, patient outcomes, and patient experience. Throughout his tenure, Dr. Ramos has held many local, state, and national leadership positions. He has also been involved in the onboarding of numerous clinical programs, including chest pain center accreditation, stroke center certification, smoking cessation, and sepsis programs. He has been integral in leading and developing Nevada's statewide antimicrobial stewardship program. Dr. Ramos spends his free time with his wife, Judy, hiking in southern Nevada, traveling, and spending time with family. They have 2 children, Adrian and Erica, and 1 grandchild, Kai. I'm very pleased to call him a friend. Dr. Ramos, I will now turn things over to you. Just let me know when you would like me to advance the slides.
Well, thank you very much. Let's go ahead and move to the next slide, please. So this is really quick. I'm not gonna read these to you, but really gonna look at what the leadership responsibility is in antimicrobial stewardship, also the role of the prescriber, and then we'll talk a little bit about how to support optimal duration for antibiotics as in the antimicrobial stewardship program. So let's go to the next slide. And I wanted to talk a little bit about I wanted to really kind of let you know what Sir Alexander Fleming said in 1945, and he was the discoverer of penicillin. Microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of a man who finally succumbs to infection with penicillin-resistant organisms. I hope this evil can be averted. And let's move to the next slide. And you can see that we have not heeded Sir Alexander Fleming's warnings, even though he stated that more than half a century ago. Again, we have bad bugs with no drugs. And if we look at the next slide, you can see patterns of resistance going back as early as 1970. So you can see MRSA, VRE, carbapenem-resistant Pseudomonas, and Cinerobacter. Let's go to the next slide. And so this really accounts for, over 30,000 deaths due to antimicrobial stewardship or lack of an antimicrobial stewardship program in place. So multi-drug-resistant organisms are killing at least 30,000, and 14,000 of those are due to C. difficile infections by themselves. Let's go to the next slide, and I wanted to talk a little bit about the role of, why it's important for skilled nursing facilities. We have over 4 million residents admitted to nursing homes every year, and that accounts for, next slide. About 70% of all residents receive 1 course of antibiotics during the year. And as we look at the next slide, you can see up to many of these residents are at increased risk for having antibiotic harm related to them. And more importantly, even residents who are not receiving antibiotics are at increased risk. And this is due to cross-contamination, either with healthcare workers or patients transmitting bacteria from one resident to another. Let's go to the next slide, Donna. So here are the main concepts and the core elements for antimicrobial stewardship. And we'll look at the next slide and look at the leadership commitment and what their role is. And I'll talk a little bit about why it's so important for leaders, especially the executives, to be on board with this. So this is the, with wherever facilities are going, it's really on the onus of the CEO to guide where we are headed in a nursing home facility or acute care facility. So what we are recommending is writing a statement of support to improve antibiotics, including antimicrobial stewardship directors in the medical director job description, as well as chief nursing officers and the consultant pharmacists in those facilities. And it's vital for the leader to communicate the role of where we're going and who's doing what to the facility. And this really starts creating a culture of safety through education, collaboration, and improved antimicrobial stewardship programs. And on the next slide are some things that I put together I thought were very important. I'm sorry, let's go to the next one as well. One more slide. So these are the things that I think are vital for a leader to really start helping facilities out with, creating short and long-term goals for the antimicrobial stewardship program. They're also responsible for providing resources for successful programs. We know that structure equals function, and sometimes we are expecting our facilities to perform miracles when they don't have the tools at hand. So some of these tools would be pharmacy expertise, infectious disease expertise, making sure nursing education is performed, and that needs to be it's an iterative process. So nurses come and go out of facility, and you can't expect to educate one time and feel like everybody's on board and is completely educated around antimicrobial stewardship. So this needs to be done either semi-annually or annually, as well as environmental services education. What is the role of the environmental service personnel in antimicrobial stewardship? It's vital when you start looking at C. difficile and the transmission of MDROs to other residents. The last thing is really, what is the data and how do we provide the data to the facility? So IT resources to track and trend data as we move forward. And I think the last big thing that the leadership needs to really do is hold the personnel accountable for reaching goals and eliminating harm. Let's go to the next slide, and we'll talk a little bit about the medical director, and then we'll talk a little bit more as the providers. So here are the facts. About 20% of the healthcare providers prescribe 80% of the antibiotics in your facilities. And hopefully, or you might see this in your own facilities, it may be up to, higher than those numbers. And then we also know that about 50% of these antibiotics may be given for longer than necessary. And this was a study done by Daneman when they looked at prolonged antibiotic treatment in long-term care facilities. And we also know that about 40 to 75% of the antibiotics are prescribed incorrectly. So we have to do a better job in making sure that we educate everybody and making sure that we have a team approach around antimicrobial stewardship program. So let's go with the next slide, and we'll talk a little bit about what the CDC recommends for the medical director. So the role is really to set standards for antibiotic prescribing and practices in the healthcare setting, oversee adherence to the antimicrobial stewardship practices, and review antibiotic data to ensure best practices are occurring. So the right drug, the right dose, and the right amount of time. On the next slide, you will see some things that I put together that I thought were vital for prescribers' role. So obviously the provider leadership, you can't write guidelines in a silo. You really need to collaborate with pharmacy, lab, nursing to create the antimicrobial stewardship guidelines, as well as I would probably pull in other providers as well. And they're also responsible for holding people accountable for the adherence to the antimicrobial stewardship program. So how do you get the buy-in? I would say probably the one thing that is vital is to make sure that we have full commitment and all providers sign the antimicrobial stewardship commitment statement. That will make them aware that they are being held to a higher standard than just coming in and allowing them to practice medicine. Provider education so that you can level set expectations with providers, let them know what you're doing and how you're doing it and why it's important for them to be on board. I would share facility data with the providers as well, because most physicians are scientists in nature, and they really are looking at data to guide their decision. And lastly, on the buy-in is make sure that you share provider-specific data with them regularly. I would not do this on an annual basis. I would do this either on a monthly basis if you need to really start moving your program forward. But if your program is up and running, you can do this on a quarterly basis. Lastly, if you can't get your prescribers buy-in, it's time to get new providers. We tolerate what we teach. And when we tolerate bad practices, we teach other people that that's acceptable. And it's time that we stop doing that and set a higher standard for us. 30,000 lives are depending on us to get this right. Lastly, peer review process, bringing people into peer review, letting them know how they're stacked up against their peers is vital for them to understand, are they an outlier or are they practicing great medicine? Let's look at the next slide, Donna. So one of the things that as we pivot to optimization of and duration of antibiotic therapy, we know that we used to do, and back when I was practicing medicine 10 years ago, we would automatically do a 7, 10, or 14 days course of antibiotics. And new evidence is showing that we can really truncate the duration of antibiotics. So when you start looking at uncomplicated urinary tract infections, you can actually do a course of from 3 days to 5 days. Community-acquired pneumonia, 3 to 7 days, where we used to do at least 7 to 10 days in the past. Ventilator-associated pneumonia is 8 days. And you can see as we start looking down, much less days are there. Even looking at meningococcal meningitis, 7 days. Back in my day, it was at least 14 days of IV antibiotics. So we can see as we start looking at data and looking at how are we treating infections, we see that we can really start truncating the amount of duration of therapy. Now, when we go to the next slide, I want to show you a little bit about how to achieve a better optimization and decrease the duration of antibiotics. One of these things is really to obtain a culture up front before starting antibiotics. This is vital, whether we're looking at blood cultures or urine cultures or skin infections. Cultures are vital. If we take the culture after antibiotics are started, it really does affect our culture and sensitivity results. So it's vital that we get these cultures started before antibiotics. The other thing is really working with the reference laboratory to use rapid diagnostics. And rapid diagnostics such as BioFire can identify an organism within 4 to 6 hours. So it really allows you to de-escalate in a more timely manner versus waiting for 3 days for the cultures to start coming back. So work with your reference laboratories about using these newer techniques. Also, make sure that you are using your antibiogram to guide your antibiotic choices as you and making sure that you are looking at what are the most causative organisms that are causing urinary tract infections in your facility or skin infections in your facility. And once you start identifying which bugs those are, you can really start focusing your therapy more targeted and making sure that you're hitting the bugs that are most likely causing the infection. And then I think instituting preventative measures are vital for any antimicrobial stewardship program. And these include hand washing, making sure everybody is getting their annual flu shots. And I highlighted it, the visitors as well. We really need to protect our patients during and residents during flu season so that we're not bringing any bugs or viruses into the facility that's causing illness for our patients. All right, next slide. And this is just talking a little bit about obtaining blood cultures prior to your starting antibiotics. And you really need to develop standards for and excessive reliability of obtaining blood cultures before antibiotics, making sure that the cultures are being collected properly and not contaminated, especially if you're doing blood cultures, and develop a process to ensure cultures are transported promptly and processed promptly. Let's look at the next slide and talk a little bit about how we start looking at antibiotics. So at the top of the graph, you have an infected patient. That's your baseline. And then the usual thing is you look at, is it a community-acquired or hospital-acquired infection? And you start a broad-based, broad-spectrum antibiotic treatment. You get after getting your cultures, and then you start looking at cultures 24 to 48 hours later to make sure, to see exactly what's growing. And you get the preliminary reports. It might be a gram negative, it might be a gram positive, and then you can start honing down and having a laser focus, a little bit closer laser focus. And then once you get the sensitivity to the antibiotics, then that's when you can really de-escalate from a broad spectrum antibiotic to one that is very focused on killing the bacteria that is causing the infection. When we start looking at, let's go to the next slide, Donna. When we start looking at antibiotic treatment, this is a kind of a little kind of record that you can track every day, and it talks about what is the initial diagnosis, what are the significant bacteriological results, so those are your cultures and sensitivities, what is the antibiotic agent you're using, what is the route of administration, doses, et cetera, and what is the planned total duration of days. And then you can really start looking at this as a plan. So review the diagnosis, get an antibiotic plan, adapt to the microbiology results, and then converting from IV to PO if appropriate. And the next slide will show a little bit different view of having the 72-hour timeout. And these are vital because what we usually do is just allow antibiotics to be continued for many days. And unless the physician says, I want antibiotics given for 3 to 5 days or 3 days or 5 days, whatever the case is, many times they go continue on and on and on. Despite cultures that might be negative, despite the patient improving, and really it's more of a reflex reaction versus a evaluation on a daily basis. Is the antibiotics, are the antibiotics continuing, or do they need to be continued, or is there something else we should be doing? Let's go to the next slide. That is all I had because I wanted to provide some comments and provide some questions for you guys, the opportunity to ask some questions, to talk about what your experiences are right now as you're moving into your antimicrobial stewardship programs. What are your pain points, and what are the things that we might be able to do to help you out with improving your antimicrobial stewardship program?
Okay. Dr. Ramos, we have Terry Cruz has raised her hand, and I've allowed her to talk. So if you would unmute yourself, Terry, you will be able to speak.
Okay, I think I'm on.
There you are.
You are.
Okay, so our medical director is not really on board for antibiotic timeouts, and he says that's only for UTIs. What are your thoughts on that?
No, that's, yeah, I would disagree with that. Antibiotic timeouts are for anybody. Now, if you already have a, you know, your bacteria, then he's correct. Most of the antibiotic timeout and the de-escalation, you know, to de-escalate is really for changing from broad spectrum antibiotics to a more specific antibiotic just to treat the bacteria.
Thank you.
Do we have any other questions? I'd like to go back to this slide where you actually have the evidence for duration of therapy. And Dr. Ramos, is there a place where they could actually find a document that has this so that they could create their own guidelines for antibiotic therapy duration?
Yes, and I'll find the link and send it out to you so we can include it in the PowerPoint that you're going to place on the website.
Okay. I don't see any questions in the question and answer box. One of the things that I've heard that people aren't bringing up right now, Dr. Ramos, is how often the prescribers actually say to them, it's none of their business how they prescribe the antibiotics. Do you have suggestions on how they approach someone like that to get their buy-in a little bit better? You know, we did talk about that a little bit, but
yeah, so yeah, the buy-in is vital, and I would say, you know, that the sad thing about physicians making that statement is they are trying to practice in a silo, and medicine is really a team sport, and I don't think we've ever realized that more than we are today. It really is vital to get the pharmacists, the executive leadership, nursing directors, and everybody else on board. I would say one of the things that I would do in that case is either have the physician, your medical director, talk to the physician and letting them know that this is not the culture that we're creating. You know, when you start looking at creating a culture of safety, it's really allowing anybody to raise a question and not to be belittled for asking the question, but really to educate so that we are all able to move to a higher level of care and improve patient outcomes. So I would say the first person I would have them talk to is the medical director, and if that didn't work, then I would have them talk with the CEO of the facility to let them know that this person is probably somebody that we need to engage and manage up or manage out.
Thank you very much. Don't see any other questions on the board here or any hands raised. If you do have something, oh, I do have one now. Go ahead and Shannon, you can unmute yourself.
Hi, Dr. Ramos. I'm calling in from New Mexico, and some of the comments that I've heard from providers are for recommendations or best practices for provider buy-in across care settings. We hear circumstances, situations where residents wind up going to a different care setting, such as acute care, and they have one clinical issue that they're sent there for, and they get returned back to the long-term care setting with an antibiotic prescription. So not only is buy-in an issue maybe internal to a facility, but you know, sometimes people have very limited access to providers who might have their own opinion on how prescribing needs to happen and not open to the facility's desire?
Great question. And I think that this really speaks to the lack of communication that we have between in the healthcare continuum. So, I would really highly recommend your CEO talking with the CEO of the facility, or talking with the chief of staff or the chief medical officer at the facility, to make sure that you're able to send your residents to a place where they are getting appropriate care. And that doesn't mean that, everybody has their opinion and everybody's trying to do the right thing. Many times it's an educational issue that physicians might just not understand what needs to happen. But I would say collaborating with from CEO to CEO, and then if you have a medical director at your facility, I would certainly make sure that they are communicating with the chief medical officer if they have one at the facility, and if they don't, then certainly the chief of staff, because you really have to make sure that you guys are on the same page as you move residents from your facility to an inpatient facility and back again. And this really also speaks to the, what do you need from the acute care facility when a patient is discharged back into your residence. Those things are vital. If they have a multi-drug resistant organism, they can certainly come back with a multi-drug resistant organism. So you need to make sure that you're aware of how your residents are being returned to you from the facility. Did that help?
Yes, thank you.
Yeah, and I see the one from Christy on several patients that are admitted to the hospital with sepsis, and there's no supporting documentation. And, sepsis is one of those things where it's a life-threatening illness. So, if a patient comes in and they think, or a resident is transferred to the emergency department, they think they're septic, they're going to give them broad-spectrum antibiotics for at least a few days until they make sure that they're not septic or will continue. The supporting documentation really needs to be done. The acute care facility needs to close the loop on it, and many times they may or may not. And it sounds like, Christy, it doesn't sound like they are closing the loop as to say the resident did not have septicemia and we're discharging him back. So I would say that, again, it's communication and collaboration with your acute care facilities that will evaluate. And you can actually look at the cases, take your cases to the facility and say, let's go through these cases. Here are the patients that are the residents we sent you. Here's they're all treated with sepsis, but there's no supporting evidence that shows that the patient was septic, yet they're coming back here on, 7 to 10 days of antibiotics. And I know you can't talk, so Christy, if you just want to say, okay, or if you have other questions, or if I answered your question on sepsis. Great. I'll take the thank you as yes, I answered your question.
Well done. That's one of the things that does definitely come up is not knowing when somebody comes to the building, if they're already on antibiotics, when they were started and when they're supposed to be stopped. And I know that we talk about this in our Nevada ASP meetings about that whole communication piece. But one of the things that I remember people talking about is having access to the infection preventionists directly at the other setting. So at the hospital, you would know who to call directly. So you're not trying to reach the nurse on the floor, but you're reaching the the infection preventionist. Is that correct, Dr. Ramos?
Yes, that's absolutely correct. And I would also say that, one of the things that's important for when you're prescribing antibiotics, the old method would be just to say, okay, give them ciprofloxacin 500 milligrams BID for 7 days. That gives you the 7 days, but a lot of times they'll just say BID. So really, we're actually asking physicians or providers to put in the diagnosis, whether it's presumptive or not, and then include a duration of time that they want the antibiotics given, so that there is a clear understanding of what the working diagnosis is and a clear understanding of how long they're going to continue the antibiotics for.
Yeah. So that goes back to this 3-day bundle, the plan that you talked about here.
Correct. But now imagine if you had this information or a lot of the information, certainly the review of the initial diagnosis and the antibiotic plan already in your physician order. That would help you out significantly. I can't imagine them putting in bacterial results in a physician order, but certainly the working diagnosis, the antibiotic duration, and how many days they're planning on using the antibiotics for.
Wonderful. Thank you. Well, we have reached
My
our
pleasure.
half an hour, so I'm going to go ahead and thank everyone for joining us. And Dr. Ramos, thank you so much for your tenacity in getting connected with us, and everyone for their patience in holding on for us. And this presentation will be, it's been recorded, so it will be posted and the slides will be available. But you'll need to give us probably a week or two to get that up there. So thank you very much, everyone, and have a wonderful day.
Thank you, Donna, and have a great day.